Thank you very much. Thanks, Society of Laparoscopy Endoscopic Surgeons of Bangladesh and Dr. Naeem and his team for this conference and this opportunity to speak in the plenary session. And the topic which has been assigned to me is there is safety in more safety. The most dangerous phrase in the language is we have always been doing like this way only. And honestly, I feel most important aspect in today's era is whether it is a corona era or post covid era it is going to be is the safety. So safety first, and I bring greetings from Institute of Minimal Access Metabolic and Bariatric Surgery and Institute of Robotic Surgery Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. There was a beautiful article in Annals of Surgery in January 2020 issue, Should Zero Harm Be Our Goal? And in this, the both the quality as well as safety have been mentioned, and safety is the avoidance of a negative outcome, whereas the quality is the achievement of a positive outcome. I think this is very, very important that if some surgery is being done, then one has to be bothered about do no harm, maximize your safety, then the quality will definitely go up. And Edward Deming, as had beautifully said, in God we trust, all others must bring data. In the global burden of post-operative deaths, that is very, very important, that it is the 7.7% of all the deaths which occur is because of the post-operative reason. And one can see that ischemic heart disease, the stroke, and then the post-operative deaths is the commonest cause of death. And the magnitude of the problem is of such a level that again, the medical error is the third leading cause of death in the US also. And in lot of publications are there, and one of the publication, surgical adverse events, reveals that overall incidence of adverse events is of the order of 14.4%, and medium percent preventability is more than 37.9%. Every year, total surgical procedures globally are done of the order of 313 million, but total deaths within 30 days is 4.2 million. So what I mean to say that more people are dying within 30 days of surgery annually from all than from all other causes related to HIV, malaria, and tuberculosis combined. So thinking is all of us as surgeons should introspect that why still the mortality is so high. And all of us know that even in US, 44,000 to 98,000 Americans die in hospital as a result of errors in care. And complications after surgery occur up to 25% of the patients, and crude mortality rate after major surgery is of the order of 0.5 to 5%. What I mean to say that even in West, the complications are occurring, the deaths are occurring. But the comedy or the tragedy of the story is that half are related to surgical care and half are preventable. Our thoughts are even in most sophisticated settings, principles of surgical safety are inconsistently applied. So we should definitely aim that there should not be any medication errors which are harming the body. There was a survey, and it was beautifully reported that the hand surgeons of the order of 1,050 hand surgeons, 21% of the hand surgeons even reported, and it is a glaring evidence that at least once in a lifetime they have done a wrong site surgery. hand surgeons doing a wrong side surgery, 21% of 1,000. That means the science of safety has to be mature enough. And one has to be believing on communication breakdowns, diagnostic errors, poor judgment, and inadequate skill that ultimately causes patient harm and death. Whether it is an error of omission or commission, or it is an error of planning, or it is a deviation from the process of care that leads to the patient's death. So our thinking is, and I fully endorse that point of Dr. Bruce Salter, that decisions are more important than incisions. And a split second becomes eternal. As Dr. Alamgir had also pointed out, that should we not think or introspect today that are we as safe as the aviation model is? Today, when I go to Dhaka, and I have been to Dhaka many times, I don't ask who is the pilot who is going to take me to Dhaka. But when the patient comes to surgeon, he always is interested, sir, you are the only one who is going to do the surgery today. So what I mean to say that have we become as safe as aviation model or not? Odds of dying in an air crash is of the order of 1 in 10 million, and odds of dying in hospital is of the order of 1 in 300. So, and when we fly, when the pilot also goes into the cockpit, he always reads this, that flying is a serious profession. Do not carry your worries beyond this point. Don't take those worries into the operation theater. So what I mean to say, distractions lead to disasters. If we are operating, we should operate, full stop. We should not be interested in baseball or cricket or any other matches at that time. And thinking is that if we are supposed to deliver one, and if we do more than one, definitely it is going to make a difference into 365 days of the order of 37.8. And if we are supposed to deliver one, but we are just 0.01 less into 365 days, then you can see that how much difference has it created. So thinking is that we should always believe that power of one mistake, power of one good deed is going to have a effect, a snowballing effect, and that will lead to disaster. And it is surprising that Jacobius in 1910 had given the statement that it is puncture itself that causes risk. So when we are putting in the X for the excess, the Viris needle or the Hassan technique, then we should be very, very careful that we are not causing any injury. Anti-injury should never be done. To err is human, to refer is divine. To err is human, to cover it up is unpardonable. And as Dr. Zamir Pasha was also mentioning, causing an injury is a mistake. Misdiagnosing it is a negligence, and mismanaging is a crime. So our thinking is that our younger colleagues, especially our younger colleagues, should be taught that all entries and exits must be shown. Defects 10 millimeter or more should always be closed. Can you imagine that this is one of the patients after sleeve gastrectomy done elsewhere? She presented to us with the features of vomiting. And when we got the CT scan done, you can appreciate that the intestinal obstruction is there. And when we did the diagnostic laparoscopy, one can find out that the intestines had gone in. When the younger surgeon must have been pulling the cannula out, the intestines had also got obstructed, stuck into the 10 millimeter port, and that has led to such kind of disaster. So thinking is that remember that life's greatest lessons are usually learned at the worst times and from the worst mistakes. So one should definitely make sure that such kind of situations do not occur in today's era. The answer is, now you can appreciate that the appendicectomy, even open appendicectomy has been done, and patient had presented with fever for 15 odd days, and then we got the CT scan done, and then we did the diagnostic laparoscopy, and you can appreciate there is a gossip bioma, there is a textiloma, it is also called as corpus ileum or retained foreign body. So all of us must have had such kind of situations in our surgical careers. But today, I think the most important lesson which one has to learn is check, 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 recheck, cross check, counter check, check and check. When we are putting in the needle, when we are putting in the suture, when we are putting in a gauze, we should always make sure that all the staff members, the sister, the technician, the OT assistant, first assistant, and everyone pronounces that needle in, needle out, gauze in, gauze out. And that is going to make a difference. So check, 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 recheck, cross check, counter check. That is the way that we can get out of our way. There, what is Kaizen? Kaizen is one small step, and that changes the way we think. That means we should do the continuous improvement through introspection. I think that is very, very important. As surgeons, we should be telling our younger colleagues, yes, if you want to be good, then anticipate one step. And if you want to be great, then anticipate 3 steps. And if we know that when the why is clear, the how is easy. That means our younger colleagues should be taught in such a manner that we should deliver our best and we should give our best for the patient. For example, there is safety in more safety. We are doing sleeve gastrectomy. We are firing the staplers. When we reach the GE junction, the top end of the junction, the staplers have been fired. But after firing 4 fires, then one starts thinking whether I should apply a clip or a suture or not. No, our thoughts are, when there is doubt, there is no doubt. One should always never ever calculate the cost of the cartridge, but one should always fire one more stapler so that the chances of leak are prevented to 0. That means all of us know that these obese patients, when they are operated, the most common cause or the common cause will be in autopsies, it will be pulmonary embolism, and actual incidence is still unreported. So our thoughts are that if, as Dr. Alamgir was also presenting, that it has to be in the protocols, it has to become a system. Then if we are following the Caprini score model, and if we are strongly believing on DVT prophylaxis, and then we are mobilizing our patients well, then these kind of patients of 235 kilo weights or 300 kilo weights who are going in for laparoscopy or robotic surgery, they will definitely be affected. So thinking is that they should become the protocols, and the safety should be the first thought in the minds of the surgeons that we are going to do. That a mistake repeated more than once is a decision. This kind of x-rays, these kind of patients we get, in which one can see even after hysterectomy, after cesarean section, this kind of artery forceps. And this is, can you imagine that this patient presented to us after 2 years of getting the cesarean section done, and you can appreciate the foreign body. We did the diagnostic laparoscopy, and this patient had been visiting the gynecologist many times for the pain pelvic region, but never ever the x-ray, never ever the investigations were done. So our thinking is have a low threshold of getting the investigations done. Patient is always right, and believe me, if we have the safety in our mind, safety as the first assignment, then we are going to do more for the patient. And this is the patient post hysterectomy. 7 years after hysterectomy, she comes with an artery forceps inside. As the Dr. Atul Gawande from New York had written a beautiful book of the checklist manifesto. I would urge my younger colleagues to buy this book, go into the depth of it, because in NAGM also, it was pointed out that checklist was found to reduce the rate of post-operative complications and death by more than 1/3. And as all of us know, in the pilot and the co-pilot, both of them do the communicate, and over-communicate, and then only the disasters are prevented. WHO also gave this surgical safety checklist. So when time in, time out, and sign out. So basic thoughts are that there are no mistakes, only there are lessons. If we are not ready to learn from others' mistakes, obviously as surgeons, we will not never be improving. Surgery is an attitude. As beautifully presented, it is a culture. If this kind of culture is there, if that kind of attitude is there in the theater, then only we will be able to make a difference. No one can motivate you if you are not willing to do it for yourself. Thank you very much. 14.7 minutes. Thanks a lot. Thank you very much.
Thank you, Parveen. Exactly.